Good morning, colleagues. Let me share with you some issues might be of possible mutual interest. Unlocking the secrecy of usage of design-driven bioengineering, biointerface-related approach towards research and translational applications as applicable to cardiology. Unfortunately, one of the co-authors is the personality was #1 in the world in autoimmunity, but died last year, HIV. Director of the Center for Autoimmunity, Johns Hopkins, and Director of Center of Human Autoimmunity of Harvard Medical School. It's a fantastic, phenomenal personality, incomparable, but died. New targeted therapies for autoimmune and inflammatory diseases would require greater understanding of a patient and now pre-illness person at risk to get the therapy individualized for either of those subsets. In this sense, the identification and application of diagnostic, predictive, and prognostic biomarkers remains the holy grail of TPM-related and translational platforms. In this context, biomarkers enable pre-illness of subclinical diagnosis, guide targeted therapy, and monitor the activity and therapeutic responses across the disorders. Just look very briefly. It's just the illustration of strategies, very brief, for discovering biomarkers. Among the best validated predictive biomarkers are autoimmunity-related ones, now cancer too, to predict and to prognosticate risks of the chronification, complications, and thus disabling. Just this information has been gifted me by my friend, director of the Center of Autoimmunity from Tel Aviv, Professor Yehuda Schronfeld. Look, it's just very brief list of biomarkers to monitor autoimmune disorder. The latter is so much valuable and important since chronic autoimmune inflammation multi-step course is structured to consist from different stages, including subclinical and clinical one. Much complicated, but it's okay. Normal immunity, healthy person. Benign autoimmunity, subclinical cryptic latency. Its named stage of subclinical autoaggression is being transformed for pathogenic autoimmunity, stage of full-term autoaggression. And finally, forming clinical illness or a feature, or a stage of full-scale clinical manifestations. As early as we can, the introduction of prophylactic, preventive, and only economical, as soon as cheaper. In last year, 2024, for autoimmunity, inflammatory, and cancer, US saved $1,200,025,000. I mean, using pre-illness person at risk. It's impossible for Europe, just only for Cambridge, even Germany that. except that Heidelberg adjusted. The diagnosis and specific and causal treatment of autoimmune myocarditis, AIM, and dilated cardiomyopathy, IDCMP, remain a major clinical challenge as applicable to PPM-guided clinical services. Moreover, the relative roles of the pathogen, host genomics, and environmental, or in more specific, exposomal factors in disease progression and healing are still under discussion, including which viruses are active inducers and which are only bystanders. As a consequence, treatment strategies are not well established yet, unfortunately. Today, together with new technologies such as MI, RNA, and gene expression profiling, quantification of specific immune cell markers, and determination of viral activity, diagnostic and predictive accuracy, and patient prognosis will continue to improve in the near future to come. Just look, it's the illustration of PPM as applicable to dilated cardiomyopathy. Illustration very brief. Differential evaluation of immunohistochemical markers in endomyocardial biopsies refines the diagnosis of intramyocardial inflammation at this point still, but invasive, informative, but invasive. However, there is a growing potential of available non-invasive diagnostic methods, including potential biomarkers, serum autoantibodies, microRNAs, speckle tracking, echocardiography, cardiac magnetic resonance, T1 and T2 tissue mapping, positron emission tomography, and the latest achievements widely known and applied in Japan and US, molecular imaging, which may refine the diagnostic workup and non-invasive follow-up. PPM-guided management should include the use of endomyocardial biopsy and antibodies, which may allow the accurate pathogenetic subsets of AIM, just remind, autoimmune myocarditis, PFAS, post-infectious autoimmune syndrome, or immune-mediated, to be distinguished, and implementation of disease-specific therapies, and to secure practical diagnostic, therapeutic, and follow-up algorithms to facilitate comprehensive individual management of those patients and now pre-illness persons at risk. Omics-driven biomarker of subclinical, clinical, predictive, and prognostic phenomena in PFAS, just remind, post-infectious autoimmune syndrome induced pre-AIM, IAM, and dilated cardiomyopathy. PPM-guided clinical practice will benefit from new developments in the area of genomics and other omics, but equally heavily depends on established biomarkers, functional tests, and molecular typing and imaging. Just look very briefly, illustration of molecular imaging as a cornerstone in cardiovascular PPM-guided clinical practice. One of the topical application of the latter 2 weeks ago, I just visited the University of Osaka. Phenomenal. Genomic-based profiling in pre-AIM and DCMP, just remind, related cardiomyopathy requires more widespread use and a higher yield of genetic testing, as well as an understanding of the functional effects of genetic variants and their diagnostic, predictive, and prognostic significance. The successful integration of comprehensive sequence analysis, including nanoportals, is the latest innovation in the area. With detailed phenotyping should initiate a new clinical principle, a new clinical framework for future evidence-based and personalized dilated cardiomyopathy. It's just individual genotype towards cardiomyopathy-related phenotypes. The interaction, balancing between genotype and phenotype, including genomics and omics profiling. In this context, the use of genetics for future cardiomyopathy prevention will rely on accurate, precise detection of individual at risk and evidence-based data for the optimal timing and type of targeted therapeutic intervention. Implementation of PPM resources and tools promises to dramatically improve patient outcomes and drastically reduce costs, not in all cardiology, since I'm not familiar with the rest, in autoimmune myocarditis, through a shift from the current focus on disease treatment to prevention and individualized therapies. The central tenet underpinning the emerging field is that a deeply detailed understanding of each person's unique profile of genetic variation, environmental, more precise, exposome-related, and lifestyle factors will allow nuanced assessment of DCMP-related risk and personally tailored interventions. However, is this just rhetoric, or are we truly standing close to healthcare revolution? Autoimmune myocarditis, again, AIM and inflammatory dilated cardiomyopathy, IDCMP. Look, please. If you would not mind, could you just read it yourself? Half a minute, relax. I have been flying 18 hours from San Francisco. Is it visible? Yes, of course.
You want to take a sip of your coffee?
No, it's okay. No, it's okay. Yeah, much better. Look, PPM guided genomic landscape and its impact and implication in cardiomyopathies. It's much complicated. I would not try to introduce deeply into the understanding. Thanks a lot. That's great. Thank you. But keep in mind, when you have in your clinical hospitals or clinics a potential patient from the family with multiple autoimmune myocarditis, just strongly suggest you to elaborate, to develop an individualized, not all-term, not full-scale, targeted profile genomic testing to identify a target or a set of targets to be used as potential targets for multi-target therapy. AIM is just one of the tissue-specific inflammatory autoimmune heart diseases, triggering immune-mediated pathological mechanisms that produces autoantibodies which attack one's own heart myocardial muscle, not all heart, leading to a myocardial damage and dysfunction, and thus to a set of heart-associated clinical symptoms. Due to the large variability in clinical presentation, unpredictable course of the disease, and lack of established causative treatment, AIM represents a challenging diagnosis in modern cardiology. Moreover, an increase in the incidence of AIM and inflammatory-related cardiomyopathy has been observed in recent years. Paradox, along with the civilized countries, that's growing rise in Bangladesh, Taiwan, and the Gulf area, for me, ununderstandable. The crucial step in the pathogenesis of a the management of AIM is complex and should be multidisciplinary, including a cardiologist, cardiovascular precision pathologist, and clinical immunologist. Thus, a uniform approach to the diagnostic process being based on the individualized biomarkers in each specific case and precision diagnostic technologies is strongly recommended. As applicable to AIM, multiple biomarkers have been extensively studied, with increasing evidence accumulating to support their clinical usefulness in acute myocarditis and, following it, cardiac myopathy. Biomarkers are routinely used in clinical practice in AIM and cardiomyopathy, and the continuum has been defined with a role possible or definite for community-based screening, diagnosis, risk stratification, prognosis, phenotyping, management, monitoring, and treatment. However, none of the canonical biomarkers has demonstrated sufficient impact alone in the management of both syndromes. Thus, it has been suggested that integration of profile multiple biomarkers or development of the principal new ones may represent promising novel strategies in AIM management, a relatively new area of modern diagnostic in the above-mentioned syndromes is the study of diagnostic predictive significance of a number of biomarkers in non-invasively obtained body fluids, including blood. The development of omics-driven technologies for cardiac biomarkers is particular for both syndromes. Just look. It's the inner infrastructure of omics technologies as applicable to AIM. In the near future, we'll allow a rapid diagnostic at home to monitor AIM as the autoimmune condition prior being hospitalized. Look, it's some of the extraction from a scope of the biomarkers of the next step generation used for AIM, not widely, but not in private clinics, just in the university affiliated hospital in Göttingen, in Munich, in Heidelberg, in Cambridge, in Stanford, UCSF, Chicago, and Houston. Osaka. Not Tokyo. Yeah, honestly, Osaka, my point of view, is the real capital of Japan, not Tokyo, since it's a lot of highly smart experts in Osaka. One of the most sensitive and specific biomarker-driven criteria for detecting AIM are cardiac troponins, and as it's known today, molecular subforms, which are regulatory protein molecules that are released into the bloodstream from cardiomyocytes upon their death or damage during the AIM progression. Look, please. May I ask you again? Read it through. Visible? Yes. Visible? Sorry. That's okay. Okay. Troponins can be used to test for cardiac injury due to AIM. Interestingly, some patients develop heterophile autoantibodies that may facilitate persistently elevated CT levels, while theoretically the presence of troponin autoantibodies may contribute to false negative results in high sensitivity CTSS. Also, troponins are not specific for identifying cardiac injuries specific to inflammatory damage. They do not have a role in testing patients with suspected AIM. Accordingly, new, highly sensitive methods for detecting anti-CT autoantibodies allow the detection of minor, tiny damages at the pre-early stages of AIM and can therefore change the understanding of disease development mechanism and open up new diagnostic possibilities. Some other biomarkers have been investigated in the setting both syndromes. However, they have not yet entered into clinical practice, and their current role is limited to the research field or only in referral centers. For instance, microRNA, myRNA, it's just scope of application. Yeah, I clearly understand, no time. Of particular interest are anti-beta-1 adrenergic receptors, beta blockers in myocarditis and myopathy. Of special and valuable interest are also anti-cardiomyosin CM autoantibodies, but not canonical. Along with canonical antibodies, some of the families proven to occur are antibodies possessing with natural catalytic activity, catalytic antibodies or enzymes, AB antibodies, enzymes, and thus belong to antibodies with a feature of functionality. It's just a slide illustrating the mechanisms of functionality. It's just the history. A family of antibody proteases detectable in AIM to cleave very specifically cardiac myosin, CM, and that's to damage the myocardial tissue. It's just the result of experiments of the letter for 1, 2, 3, 4, 5, 6 years. As you might see, there should be, I will present the next step lecture of devoting to catalytic antibodies in myocardium. As you might see, there should be more focused research on studying the role of antibodies and autoimmunity in the pathogenesis of not only myocarditis, but also in the development of myopathy. In this context, omics studies should be crucial to identify genetic association for prevalence of cardiac autoantibodies of the next step generation. The field of cardiology. Okay, 2 minutes. Is evolving to provide the practice with biomarkers of principally new generation, which are applicable for biomarker-driven targeted therapy, which is crafted as per the omics technologies to deep phenotyping. New armory. PPM globally and PPM guided cardiology practice proposed to be the future of cardiology and holds the potential for a more efficient and personalized approach to the management of cardiovascular diseases, contrary to standardized blind approach. Thank you so much for your patience.